Hello, and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shamagam. When I was a fellow, I was lucky enough to serve on the Fellows Subcommittee of the American College of Rheumatology, and I was assigned to be the Fellow in Training representative to the annual meeting planning committee. It was a fabulous way as a trainee to get insights into how the college works, and it also gave me a great opportunity to interact with rheumatologists outside of my program. Some of those rheumatologists have become friends and mentors over the course of my career, and it's a very great pleasure to have one of them on the show with us today as my guest. Dr. Richard Fury is the Marilyn and Barry Rubenstein Chair in Rheumatology and Professor of Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra and Chief of Rheumatology for Northwell Health. Rich was the chair of the AMPC when I was the FIT representative, and he has been a great mentor and good sounding board for me during my career, and I know for many rheumatologists around the world. Rich, it's a pleasure to have you on the show today. Welcome.
Thank you so much, Vicky. So that was a lot of years ago. That was about 20 years ago. It was a great committee.
Now you're making me look old. So the manuscript we're going to be talking about today was presented at ACR Convergence and published in Arthritis and Rheumatology to coincide with the start of the ACR meeting. It's entitled A Randomized Placebo-Controlled Phase 3 Extension Trial of Long-Term Safety and Tolerability of Anifrolumab in Active Systemic Lupus Erythematosus. There's a link to the manuscript in the show notes from today, as well as disclosures regarding this manuscript because it's an industry-sponsored study. And this study is an extension of the original two TULIP studies, and TULIP in this context stands for Treatment of Uncontrolled Lupus via the Interferon Pathway. Anifrolumab is a fully human monoclonal antibody to type 1 interferon receptor, and it inhibits signaling of all type 1 interferons. So Rich, to start us off, I wondered if you could give us some background and remind us about TULIP 1 and TULIP 2.
Sure, but let's in fact go back before the TULIP studies to the phase 2 study known as MUSE, which was a typical SLE trial that enrolled patients with active disease as determined by both SLEDAI and BILAG. The results were quite robust and an absolute pleasure to present at the ACR meeting about 7 or 8 years ago. Although the primary endpoint was the SRI, a composite index composed of SLEDAI, BILAG, and PGA, there were robust results using the BICLA, another composite index, where the driver of efficacy is BILAG improvement. Given the marked success of the phase 2 study, we did not tamper with the design of the phase 3 program very much. TULIP 1 studied 2 doses, 300 milligrams and 150 milligrams of anifrolumab, compared to placebo, whereas TULIP 2 studied the 300 milligram dose compared to placebo. Based on the phase 2 results, there was a lot of confidence, an enormous amount of confidence going into the phase 3 program. However, to the absolute shock of the lupus community, TULIP 1 did not achieve statistical significance. But a detailed analysis demonstrated a robust response with the BICLA as the endpoint. Now, TULIP 1 enrolled quicker than TULIP 2, and thus was unblinded before TULIP 2. After a lot of discussion, it was decided to change the endpoint of TULIP 2 from the SRI to the BICLA before data were unblinded. And I emphasize before unblinding. TULIP 2 was successful using the BICLA as the primary endpoint, but there was no need to have changed the endpoint as the SRI had a 2 percentage point edge over the BICLA. So we had one positive study and one negative study. But the negative study, TULIP 1, was not so negative. Many of the secondary endpoints were positive, like BICLA, steroid taper, CLASI, and joint scores. Although there was a lot of anxiety about how regulatory authorities would handle the discordant results, in the end, the FDA approved anifrolumab in August of 2021.
I remember that whole story playing out and some level of anxiety and concern in the community as the data were presented. But the FDA did approve the drug for the treatment of patients with moderate to severe lupus receiving background therapy. And it's important, I guess, that we mention neither of the two TULIP 1 or TULIP 2 studies enrolled patients with active lupus nephritis or CNS lupus. So the drug is not approved for those indications, correct? Can you tell us a little bit about this extension study? I think the purpose was to allow patients who'd already been receiving anifrolumab to continue to receive treatment. Some of the placebo patients also switched into the treatment arms. Can you tell us about that and how it was set up?
Yeah, unlike most extension studies, which are open label, this extension study was a unique design in that it remained placebo controlled for 3 years. And the obvious advantage of a placebo controlled trial is that one can make more valid comparisons of safety and efficacy. Patients on 300 milligrams of anifrolumab remained on that dose. Those on 150 milligrams were increased to 300 milligrams. And remember, that was just in TULIP 1. And those who were on placebo were randomized 1-to-1 to 300 milligrams of anifrolumab or remain on placebo. So 547 of the 639 patients who completed the 1-year TULIP studies enrolled in a long-term extension. 257 continued anifrolumab 300 milligrams, and 67 transitioned from anifrolumab 150 milligrams to 300 milligrams. The 223 patients who had received placebo in TULIP 1 or TULIP 2 were re-randomized to anifrolumab 300 milligrams or placebo in the long-term extension. I don't know if you got all of that.
Yeah, and I have some questions actually, because when you look at the data, it looks like at the point of entry into that long-term extension portion of the study, even the placebo patients had better disease activity scores than at entry to the original studies. And I'm interested to know why that might be and what impact that has when we look at the results of the long-term extension study. Is it that people who developed active disease and we're in that placebo arm, we're dropping out?
It is certainly true that both groups improved in the first year of the study, but there was greater improvement in the treatment arm compared to the placebo arm. Both groups started out with SLEDAI scores over 11 in the first phase of the TULIP studies, whereas at the start of the long-term extension, there was about a 1-point difference in favor of anifrolumab versus placebo, 5.1 versus 6. The fact that patients on placebo improved is not at all surprising, as we typically see placebo response rates in the 30 to 40% range. In fact, the high placebo rate has been our nemesis. We would love to reduce the placebo response rate, but that is a whole nother discussion. So remember, the goal of the long-term extension was to explore safety as opposed to efficacy, although efficacy was evaluated.
So actually, I'm going to flip on your head then, because I want to talk about efficacy first. But before we do that, I wondered if we could talk first about your thoughts regarding attrition rates. So both the treatment and the placebo arms during the extension phase of the study had pretty significant attrition rates. It looks like about 30% of the people receiving active drug and 50% of the placebo group dropped out. Why do you think that was? And do you think that impacts how we interpret the results?
Yeah, no, you're absolutely right. So in our studies, we generally observe about 15 to 20% dropout rate every year. So the 30% and 50% are right on target in a 3-year study. But again, this study focused on safety based on exposure to drug. And that is why the results are adjusted and expressed as an exposure-adjusted incident rate, or EAIR. So efficacy was a secondary endpoint. When patients drop out of studies, the strictest imputation method is non-responder imputation, where a dropout is considered a non-responder regardless of how they were doing when they left the study. So how to handle missing data can be a nightmare for statisticians. So I don't think the dropouts affected the safety data very much due to the adjustment, nor the slope of the SLEDAI curves over time. But be that as it may, the most common reasons for withdrawals in the long-term extension were, number 1, withdrawal by patient, number 2, adverse event, 3 was lack of efficacy, and 4 was loss to follow-up.
I agree. I think we see that a lot. And I guess across all lupus studies, that's a common challenge. Let's talk a little bit about efficacy. And I do know that that was not your primary goal with this study. Tell us what you looked at in terms of efficacy for this study and what you found, because efficacy outcomes are always tricky in lupus trials too. So tell us what the lupusologists had decided to study here.
Yep, that they are. So, in the first part of the study, the composite indices, SRI, which stands for the SLE Responder Index, and BICLA, the BILAG based composite lupus assessment, were used. These indices are dichotomous and declare a participant either a responder or non responder. But the principles of the two indices are about the same. That is, one needs to improve in active domains and not get worse in yet other domains. The driver of efficacy is the SLEDAI for the SRI, whereas the BILAG is the driver of efficacy for the BICLA. The physician global assessment is also incorporated. And of course, patients cannot take prohibited medications, else they are considered non responders. Now, the long term extension study was primarily designed to assess long term safety, but disease activity was assessed with the SLEDAI 2K. I would say the most meaningful comparison is between the patients who remained on anifrolumab throughout, so we're talking about 4 years, and those who remained on placebo throughout for 4 years. Greater mean improvement was observed for patients in the combined anifrolumab 300 milligram group than for patients in the combined placebo group. Improvement was sustained over time, and the mean disease activity levels remained low with anifrolumab throughout the study. The SLEDAI scores at the end of the long-term extension were 3.4 in the anifrolumab group versus 4.0 in the placebo group. It should be emphasized once again that the long-term extension was designed to reflect real-world clinical practice by allowing investigators to add or change background standard care treatment. And this could include immunosuppressives, glucocorticoids, without any penalty to efficacy status. However, biologics and cyclophosphamide or even IV steroids were not permitted.
So let's talk about glucocorticoid use here, right? Because we know that actually that can be a very toxic medication. You did show differences in glucocorticoid utilization between the two arms as well, right?
We did. We've had a love-hate relationship with steroids since 1948. Compound D, or cortisone, was discovered. So the ability of a therapeutic intervention to spare steroids is very welcome, not just by lupus doctors, but every doctor. Treatment with anifrolumab enabled a steroid dose reduction. We also observed a lower cumulative glucocorticoid dose compared with placebo. And I should emphasize that in the long-term extension, unlike the first phase of this study, that there was no glucocorticoid taper requirement. At year 4, about 36% of the patients on anifrolumab were free of steroid use, and 90% of patients were receiving a dose less than or equal to 7.5 milligrams per day. This is in contrast to 27% and 70% in the placebo group. So we're talking about a 9 to 20 percentage point edge in both metrics in favor of anifrolumab.
Right. And probably that's very real in terms of glucocorticoid exposure risk and side effect risk, right?
Yes.
So I'm intrigued by the kind of long-term follow-up study design in lupus trials, and I wondered if you could give us your thoughts on this. Here you had patients who were relatively well controlled at enrollment into the extension phase, but we know that lupus is a disease that flares somewhat unpredictably. And so I'm curious, do you ever look at any measures of sort of durability of remission, whether it be time to flare or some kind of, survival analysis with time to relapse? I feel like that is something our patients and definitely as clinicians, we'd quite like to know for long-term therapy. Is anifrolumab a good agent as a remission maintenance agent?
Oh, we absolutely look at flares in all of our studies because what we know about lupus is disease activity, and flare is obviously an increase in disease activity. Disease activity begets damage, and damage begets more damage, and damage is closely linked to mortality risk. So the name of the game is to reduce disease activity or flares. So utilizing the Selena flare index, the overall annualized flare rate was about 10% in the combined anifrolumab 300 milligram group versus 20% in the combined placebo group. But flares in both groups were mostly mild to moderate in severity.
Yeah, is that in part because patients with sort of active organ-threatening disease are excluded from the study at the get-go? Do you think that's partly accounting for the difference?
Well, I mean, you're dealing with a population where, you said it in the beginning, where severe lupus nephritis was excluded, CNS disease of great severity was excluded. And then, some of your withdrawals are patients who are very sick, who are flaring. So there's selection bias.
Right. And I guess that's inevitable because of how the studies are designed and because the studies are obviously designed with safety in mind also, right, for the patients. So let's talk a little bit about safety outcomes in this study, because I know that was one of your primary goals when you set this up. In particular, I think you'd seen some increased rate of zoster reactivation in one of the original TULIP studies. Did that risk persist?
Yeah, so we noticed that back in the phase 2 study. And it's not at all surprising that there's reactivation of herpes zoster, given the mechanism of action of this drug. Basically, it inhibits the type 1 interferon pathway. And if you go back to 1957, that was the discovery of interferon. So it's a very interesting history. And the investigators in London were using an influenza virus model where they took influenza virus that was capable of replicating, heat inactivated it so it could not replicate it, and they injected it into a chicken egg, into a chicken embryo. Then they challenged that chicken egg with virus that could potentially replicate. And what they found is that the virus could no longer replicate. So there was something being produced by the chorioallantoic membrane in the chicken egg, and they first called this viral interference, and they then shortened it to interferon. So we grew to know interferons as part of our host defense against viruses. So if we're inhibiting interferons, it wouldn't be surprising if we saw certain viruses act up. And so herpes zoster was one. So in the phase 2 study, we saw a zoster signal. And in the pooled phase 2 and 3 data, zoster was about 5-fold higher in the anifrolumab group. So despite being typically single dermatomal involvement and responsive to antivirals, I make sure my patients starting anifrolumab receive Shingrix. In the long-term extension, although the rate of shingles was higher in the anifrolumab group, it was 3.4 versus 2.8 per 100 patient years. The frequency was lower than what was observed in the first phase of the study. And that was, in the first phase, was a little bit over 6 cases per 100 patient years. So why the reduction in rates? Well, I don't know, but perhaps the reduction in steroids over time could have had something to do with this rate reduction. Along the same lines, influenza cases were more common in the anifrolumab group. It was 2.2 versus 0.8. And this is not at all surprising.
So since we're talking about viral infections, this study obviously spanned the COVID pandemic. We know or knew that that was a concern as the COVID pandemic was evolving. People, I think, were quite worried about interferon agents. Can you tell us what you found in regards to COVID infection outcomes in this population, and then any data on vaccine responses for these patients?
Yeah, the interpretation of the COVID data, I think, is complicated. But the pandemic occurred during the latter part of the extension study. There were approximately 325 patients on anifrolumab at the start of the pandemic and about 60 on placebo. And this translated to a total exposure during the COVID pandemic of 228 patient years for anifrolumab and just 43 patient years on placebo. So event rates for COVID-related serious adverse events, which were based on time at risk during the pandemic, were higher in the anifrolumab group compared with the placebo group. It was 7.2 versus 2.4. And the absolute numbers were relatively low. Again, we're talking about serious adverse events. It was 12 for anifrolumab, 1 for placebo. There were 3 deaths that occurred from COVID in the anifrolumab group, and they occurred in 3 different countries and within the first 6 months of the pandemic. 2 of these individuals were on immunosuppressives. Now, as far as COVID vaccines, only 21 people in the anifrolumab and 9 in the placebo group were fully vaccinated during the study. No COVID-related adverse events occurred in patients after they were fully vaccinated, though again, the exposure following vaccine introduction was limited. So I think it's very hard to interpret the COVID situation in the long-term extension, given the relatively small numbers of participants, the variability in care across the world. Remember, this was a global study. The subsequent introduction of treatments, not to mention vaccines. So COVID was and remains a moving target for sure.
Are you continuing to follow these patients? And is that something that you're likely to get ongoing data to guide us?
No, not that I know
A
of.
couple other questions regarding safety in this study. Did you see any increased signal of TB?
There were no active cases of TB, but there were cases that were classified as latent TB based on annual interferon gamma release assays that were required. And the rates were 2.3 versus 0.8 anifrolumab to placebo. But there were no opportunistic infections.
Yeah, and then how about malignancy risk?
Rates of malignancy were quite low, less than one case per 100 patient years, and they were similar between the anifrolumab and placebo groups.
So looking good so far in that regards then.
Absolutely.
So it seems all is rosy in the field of tulips, even during the pandemic. As we kind of come to a close, Rich, I like to give people a chance to get to know the person behind the paper. And so I wondered if you could share any stories of mentors who've shaped your career over the years.
Well, I look back to my fellowship at Hospital for Special Surgery, and my mentors were Charles Christian, who passed, probably about 6 or 7 years ago, and Michael Lockshin, who I don't want to insult him, but he's probably closing in on mid-80s, and he's still working. So they introduced me to lupus, and I left Hospital for Special Surgery and came out to Long Island and set up a lupus clinic. A little did I know, almost, 40 years ago, that it would develop into a huge center and we would be internationally recognized for many of our clinical research projects.
Yeah, and you have a huge department out there on Long Island, right?
Well, we're somewhere over about 50 rheumatologists throughout the entire health system and continuing to grow.
That's fantastic. I know it's hard to do virtual mentorship for a large audience that you cannot see, but I know that as a hobby, you are a pretty serious sailor. And so I'm interested to know your advice on how to weather storms at sea and what to do when the wind blows you off course.
Sure. Stay upright. And all of that's dependent upon the keel. So, interesting story. We just had the Euro Lupus meeting in Stockholm. And one of the social events in the evening was at the Vasa Museum. And the Vasa was a ship commissioned by Sweden, designed by Danish naval architects. And within 20 minutes of launching, and we're going back to the 1600s, the wind blew it over and it sunk.
Oh, no.
It needed a bigger keel. So my advice is to stay even keeled. There's always a solution. You may need to ask for advice, but stay even keeled.
And I guess looking back over the course of your career, which has obviously been very successful, are there any pivot points where, with the benefit of wisdom and hindsight, you wish you could reach out and give some advice to your younger self?
Well, that would be cheating. That's what life is all about. Exploring. But I would say, and I actually just had this discussion with one of our fellows, I think diversity is the key to a career. Get involved in many different things. And that's how I met you. I hate to say this, I have it recorded, in fact. I didn't used to go to the American College of Rheumatology meetings because I was out sailboat racing. But Peggy Crow got me involved. She was the AMPC chair at the time and put me on the committee in 1998. It was a wonderful experience. And then I just kept rising in rank. And it was just a great thing to do. And my advice is never say no. Get involved with everything that you can.
That gets us back to the chicken eggs, right? And don't put all your eggs in one basket, I guess. So great advice. I want to thank you for sharing it with us. And thank you for coming on the show today, giving us your take on the TULIP studies. It's certainly been fun peeling back the petals and talking mentorship with you. So thank you all for listening to this show. This episode, I want to take a moment to thank mentors throughout the field of rheumatology. Mentorship comes in many forms and is a little bit like mental philanthropy, one of those unique gifts that's both wonderful to give and to receive. Thank you to our mentors for making our field stronger and wiser. ACR Journals on Air is a production of the American College of Rheumatology, Please follow at AC Room on social media and also rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.